Let me ask you something uncomfortable. What if the blood pressure number your doctor called borderline, the one where they said, let's just keep an eye on it, is the exact number that puts you at highest risk for a silent stroke? And what if the number that sent you rushing to the pharmacy for a new prescription was actually doing your heart a favor? I know that sounds backwards, but after decades studying cardiovascular risk in older adults, I can tell you this with certainty. Most people over 60 are not confused about whether their blood pressure is high. They are confused about what high even means for a body that has been running for 6 or 7 decades. And that confusion right there is costing people their independence. Today, I'm going to hand you a complete framework, not a talk to your doctor brush off, a real evidence-based answer to the question, how high is too high specifically for your age, your body, and your risk profile. And I'm going to show you a number hidden inside every blood pressure reading that almost nobody calculates, one that predicts your stroke risk more precisely than the numbers your doctor actually writes down. Stay with me through the whole video because the section at the end on what I call the danger window, a specific time of day when blood pressure quietly does its worst damage, could genuinely change how you protect yourself. My name is Dr. Franklin, and I work specifically with adults over 60. My focus has always been the same, not just treating disease after it arrives, but understanding the signals the body sends long before the damage becomes visible. This channel exists because the conversation most older adults need to have about blood pressure, a real, detailed, nuanced one, almost never happens in a 12-minute office visit. We are still a young channel, and if what you hear today gives you something genuinely useful, I want to ask you to subscribe right now, not later now. Because every subscriber tells YouTube this content is worth showing to someone else who needs it. Hit that button and let us keep going. Here's the problem with the way most people think about blood pressure. They want a single number, a threshold, a line they either cross or they don't. And I understand that instinct. It is simple, it is clean, but it is also dangerously incomplete. The Centers for Disease Control reports that nearly 70% of adults over 65 have hypertension, high blood pressure as officially defined. But here is the part nobody talks about. A significant portion of those same adults who get medicated based on office readings do not actually have sustained high blood pressure when measured correctly at home over time in a resting state. They were treated based on a snapshot that did not represent their real baseline. Meanwhile, and this is the part that keeps me up at night, some adults with readings that fall just inside the acceptable range are quietly accumulating damage. Not because their peak number was too high, but because of patterns in their blood pressure that a single office visit will never reveal. So let's reframe the question. Instead of asking, is my number too high? Okay, I want you asking 3 better questions. First, too high compared to what? A resting baseline or a reactive spike? Second, too high for how long? 1 reading, 1 week, 1 year. Third, too high in which direction? The top number, the bottom number, or the gap between them? Each of those questions leads to a completely different answer, and each of them corresponds to a different kind of damage happening in a different part of your body. Let me walk you through all 3 because once you understand this framework, a blood pressure reading stops being a source of anxiety and starts being a source of information. Before we get into this, I'd love to hear from you. Where are you watching from today? Drop your city or country in the comments. I read every single one, and it really helps me see who's part of this community. All right, let's get started. Every blood pressure reading gives you 2 numbers. You know this, but what most people do not know is that after 60, these 2 numbers often start moving in opposite directions. And that divergence is one of the most important signals in all of cardiovascular medicine. The top number, systolic pressure, measures the force your blood exerts against your artery walls when your heart contracts and pushes blood out. Think of it as the pressure wave that hits every time your heart beats. The bottom number, diastolic pressure, measures the pressure between beats when your heart is refilling. This is the background pressure your arteries live with constantly, even at rest. Here is what changes as we age. Our arteries stiffen. This is not optional, it is biological. The elastic fibers inside arterial walls gradually lose their flexibility, a process called arteriosclerosis. And when arteries stiffen, 2 things happen simultaneously. The systolic pressure goes up because the stiff artery cannot expand to absorb the wave. So the pressure spike with each heartbeat gets more intense, and the diastolic pressure often goes down because the stiff artery does not recoil between beats the way a healthy elastic artery does. So the resting pressure drops. Result: the two numbers spread apart. Top goes up, bottom goes down, or stays flat. This pattern, elevated systolic with a normal or low diastolic, is called isolated systolic hypertension. And it is the dominant form of high blood pressure in adults over 60. The majority of hypertension in older adults looks exactly like this, and it behaves differently than the kind of high blood pressure most younger people develop, which affects both numbers equally. Why does this matter? Because isolated systolic hypertension carries a very specific risk profile. A large analysis using data from the Framingham Heart Study found that elevated systolic pressure in older adults was one of the strongest independent predictors of stroke, heart failure, and cardiovascular death, even when diastolic was perfectly normal or even low. So if your doctor looks at your reading, sees a bottom number of 72 and says, well, the diastolic looks fine, that is an incomplete assessment. The top number can still be doing real damage even when the bottom number is reassuringly normal. Now let me give you the specific numbers that matter, the real danger zones, what the research actually says. I want to be precise here because this is where most conversations go vague, and vague is not helpful. The landmark clinical trial that reshaped blood pressure treatment for older adults is called the SPRINT trial, published in the New England Journal of Medicine in 2015. It enrolled 9,361 adults, most of them over 60, and asked a direct question: does treating blood pressure more aggressively reduce cardiovascular events? The answer was yes, but with important caveats that often get left out of the headline. SPRINT found that targeting systolic pressure below 120 reduced the primary composite cardiovascular outcome, heart attack, stroke, heart failure, and cardiovascular death by 25%, and reduced all-cause mortality by 27%. But it also found meaningfully higher rates of acute kidney injury, dangerously low blood pressure on standing, fainting, and electrolyte imbalances. Real risks that have to be weighed carefully against the cardiovascular benefits, particularly in adults over 75. So when I give you ranges, I am giving you the full picture, not just the upside, but the risk of going too far in the other direction. For adults aged 60 to 74, systolic below 130 at consistent rest. This is the target zone, systolic 130 to 139. Acceptable but worth monitoring closely. Systolic 140 to 149. This is the early warning zone. Not yet a crisis, but lifestyle changes and a serious conversation with your physician are warranted. Systolic 150 or above consistently over 2 weeks or more. This is too high. This needs medical attention. For adults 75 and older, below 140 systolic remains the goal. But how aggressively you pursue it depends heavily on kidney function, risk of fainting or low blood pressure on standing, and overall health status. 150 and above consistently too high regardless of how you feel. For the diastolic, the bottom number below 80 is ideal. 80 to 89 needs watching. 90 or above consistently damaging. Arteries and kidneys are under sustained excessive strain. But, and I need you to hear this clearly, diastolic below 60 is also dangerous in older adults. This is the direction of risk most people never think about. A study published in the Journal of the American College of Cardiology using data from the ARIC cohort found that diastolic consistently below 60 was associated with significantly higher rates of subclinical myocardial damage and coronary heart disease events, not because pressure was too high, but because there was not enough pressure between heartbeats to properly peruse the heart muscle itself. A separate study in the journal Hypertension confirmed that in elderly patients with isolated systolic hypertension, diastolic at or below 60 was an independent predictor of mortality. I had a patient, I'll call her Evelyn, 77 years old, a retired librarian from Georgia. She came in dizzy, exhausted, and deeply worried. Her systolic was well controlled at 126, but her diastolic had drifted down to 54 over several months on a multi-drug regimen. Her heart was not getting adequate blood supply between beats. We carefully adjusted her regimen, and within a month, her diastolic returned to 68. Her dizziness resolved, and her energy came back almost immediately. Nobody had looked at the bottom number going too low. They were so focused on keeping the top number down that they created a new problem beneath it. Watch both numbers, not just the top. If you're still here with me and finding this helpful, take a moment to type 2 in the comments. It lets me know you're watching and getting value from this. Now, I want to give you something most doctors will never calculate for you in an office visit. A number you can derive yourself in about 5 seconds from any reading you already have. It is called your pulse pressure. Pulse pressure is simply the difference between your systolic and diastolic. If your reading is 148/78, your pulse pressure is 70. If it is 132/82, your pulse pressure is 50. That gap, that single number, is one of the most powerful cardiovascular risk predictors available in older adults. A landmark Framingham heart study analysis published in the journal Circulation found that pulse pressure was a stronger predictor of major cardiovascular events in adults over 60 than either the systolic or diastolic number alone, and that from age 60 onward, diastolic pressure actually became inversely related to heart disease risk, meaning a wider gap carried more danger, not less. Why? Because pulse pressure is a direct real-time measurement of arterial stiffness. Stiff arteries push the systolic higher and let the diastolic fall lower. The gap widens. And a widening gap means your heart is working harder with every single beat, generating more mechanical stress on arterial walls, including the walls of the coronary arteries that feed the heart muscle itself. Here are the ranges. Below 40, normal arteries are maintaining good elasticity. 40 to 60 acceptable but worth tracking over time. Begin paying close attention. Above 60 warning zone, this signals meaningful arterial stiffness and elevated risk. Above 80, this is a serious signal. If your reading is 165/75, most people look at that 165 with concern, but the pulse pressure is 90, which tells us the arterial wall mechanics are under severe stress. That number deserves as much attention as the top number, if not more. Take any reading you have from the last week, subtract the bottom from the top, write that number down. If it is above 60, bring it to your next appointment and specifically ask your physician to address it. Most will not have raised it themselves. Now, you will. And if you've made it this far, and you're getting value from this, type the number 3 in the comments. It's a simple way to let me know you're here and following along. Here's the piece I promised you at the beginning that most people never hear. Blood pressure is not a fixed number. It moves throughout the day, sometimes dramatically. And there is one window of the day when blood pressure is known to be at its most dangerous for older adults, and it is almost never discussed. It is the morning surge. In the 2 hours after waking, roughly from the moment you open your eyes to about 90 minutes later, blood pressure naturally rises sharply in most people. This is driven by the release of cortisol and adrenaline as the body wakes up, combined with a sudden increase in heart rate and sympathetic nervous system activity. In healthy younger adults, this surge is modest. But in older adults with arterial stiffness, this surge can be dramatic. 20, 30, even 40 points above nighttime baseline. Research published in the journal Circulation established that the hours between 6 a.m. and noon account for a disproportionate share of strokes and heart attacks in older adults, and that the morning surge in blood pressure is a primary driver. A landmark prospective study of 519 elderly hypertensives found that older adults with a high morning surge had a relative stroke risk of 2.7, nearly 3 times higher, compared to those with a blunted surge even after controlling for 24-hour average blood pressure. What this means practically: if you take your blood pressure once a day and you take it at 300 p.m., you may be measuring your most benign window. Your morning reading taken within 30 minutes of waking, before coffee, before medication, before any physical activity, is far more clinically revealing. I had a patient, I'll call him Gerald, 71 years old, a retired school principal from Virginia. His afternoon readings were consistently around 132/78, perfectly acceptable. He felt fine, but on a hunch I asked him to take readings for 2 weeks at 3 specific times, within 20 minutes of waking, at noon, and at bedtime. His morning readings averaged 158 systolic. The same man who looked well controlled in the afternoon was running dangerously elevated for the first 2 hours of every day, 5 days a week, right through his morning walk and his first cup of coffee. We adjusted the timing of one of his existing medications to provide better morning coverage. His morning readings dropped to 134. His afternoon readings were unchanged. If we had never measured the morning, we would never have found the danger. Measure your blood pressure in the morning. It is one of the most important things you can do. Now, all of this analysis depends on one thing: that your readings are actually accurate. And that is a much bigger problem than most people realize. There are 5 mistakes I see constantly, and each one can artificially inflate your reading by 10 to 20 points. Stack them together, and you can add 30 to 40 points that do not reflect your real blood pressure at all. Mistake 1: not resting before you measure. Blood pressure rises immediately with physical activity, even walking to the bathroom. Research confirms that measuring without proper seated rest can meaningfully inflate your reading, particularly in patients with already elevated pressure, which is exactly when an accurate number matters most. Current guidelines from the American Heart Association recommend a minimum of 5 full minutes of quiet rest before any reading is taken. 5 minutes sitting still before every reading. Mistake 2: measuring over clothing or with the arm hanging. The cuff must be on bare skin, and your arm must be supported at heart level, not dangling, not resting in your lap. A dropped arm position alone can add 8 to 10 points due to the hydrostatic effect of blood pooling downward. Mistake 3: using the wrong cuff size. A standard adult cuff on a larger arm produces falsely elevated readings. This is extremely common and almost never checked. If you are unsure, ask your pharmacist to verify your cuff size. It matters more than most people think. Mistake 4: full bladder, crossed legs, or active conversation. A full bladder raises systolic by an average of 10 to 15 points. Crossed legs add 5 to 8 more. Confirmed across multiple controlled studies including Keel-Smith and Price-Daniel 2001. Talking during the measurement, even responding to a nurse's casual question, adds another 10 or more as documented in automated BP monitoring research. That is a potential 25 to 30 additional points from things you can completely control. Mistake 5: measuring only once and trusting that one number. Blood pressure is highly variable. A single reading is almost meaningless in isolation. Take 2 readings 1 minute apart and use the lower of the 2. Then track a pattern. At minimum, a full week of morning and evening readings. The correct protocol I recommend to every patient over 60 is this: 5 minutes of quiet rest, feet flat, back supported, arm bare, and at heart level. 2 readings 1 minute apart, recorded twice daily. Once within 30 minutes of waking, once in the evening, 7 consecutive days. Average all the readings. That average is your real blood pressure. That is what should guide treatment decisions, not one reading in an exam room. One of the most common questions I receive is this: when does a high reading stop being something to monitor and start being something that requires immediate action? Here's the framework. A high number without symptoms is a signal to respond methodically, not to panic. Sit down. Rest quietly for 10 minutes. Breathe slowly. Retake. In the majority of cases, a reading that looked alarming comes down significantly after genuine rest. Stress, anxiety, caffeine, even the act of worrying about your blood pressure can spike it 20 to 30 points temporarily. A high number with specific symptoms is a different situation entirely. If your reading is above 180 systolic or above 120 diastolic, and you are experiencing any of the following, call emergency services immediately. Do not drive yourself. Do not wait to see if it passes. The symptoms that make a high reading an emergency: severe sudden headache unlike anything you felt before, chest pain or pressure, sudden difficulty speaking or understanding speech, vision changes or partial vision loss, numbness or weakness on one side of your face, arm, or leg, or sudden severe difficulty breathing. These symptoms, alongside a very high reading, suggest hypertensive crisis, blood pressure actively damaging organs in real time, brain, heart, kidneys, eyes. Minutes genuinely matter. But know this: many people experience readings in the 170s or even 180s with zero symptoms, particularly in the context of stress, anxiety, or poor measurement technique. That does not require an ER. It requires rest, remeasurement, and a same-day or next morning call to your physician. Know the difference between a spike and a crisis. That distinction alone may save you from years of unnecessary medication or save your life when you need to move fast. Let me bring this together because I want you to leave this video with something concrete. Not just something you heard, but something you can actually use today. You now know that too high is not a single threshold. It is a question of which number, which pattern, which time of day, and which direction. For adults 60 to 74, systolic target below 130, 140 to 149 needs attention. 150 or above consistently is too high. For adults 75 and older, target below 140. 150 and above consistently is too high at any age. Diastolic above 90 is too high, but diastolic below 60 is equally dangerous, and almost nobody watches for it. You know to calculate your pulse pressure, the gap between top and bottom. Below 40 is healthy, above 60 is a warning. Above 80 is a serious signal of arterial stiffness and elevated cardiovascular risk. You know about the morning surge, the most dangerous window of the day for older adults, and why your morning reading is the most important reading you will take. Most people never measure it. You know the 5 measurement mistakes that can add 30 or more false points to any reading, and you know the correct protocol. 5 minutes rest, bare arm, 2 readings twice daily, 7 days, average them all. And you know the difference between a spike and a crisis. A high number with no symptoms calls for rest and monitoring. A high number with sudden severe symptoms calls for emergency services immediately. I want to ask you directly, do you know your morning blood pressure? Have you ever calculated your pulse pressure? Go to the comments and tell me. I read every comment on this channel, and I respond to as many as I can. Your question may become the subject of a future video. If this gave you real clarity, do 3 things. Subscribe if you have not already. Hit the like button. It helps more people over 60 find this content, and share it with someone you care about who is navigating blood pressure concerns. The information that finally makes something click for someone you love may be sitting right here. Blood pressure is not a verdict. It is a conversation between your body and your environment. Now you speak the language. I am Dr. Franklin. Take care of yourself because the people who love you are counting on you to be